started. So thank you everyone for coming to our Rural Health Seminar Series. We are online today on Zoom. Before we begin today, I would like to just acknowledge and pay respects to the traditional custodians of the lands upon which we are meeting today. Today I'm on Witjabul country, Bundjalung Nation. I'd like to pay respects to elders past and present, and I recognise their connection to country and integral role in caring for and maintaining country over thousands of years. I also would like to extend that respect to First Nations people who are joining us today. So just before we begin, some very brief Zoom housekeeping. Please keep your microphone muted during the presentation. And I just do need to let you know that this seminar is being video and audio recorded. There will be time for questions at the end of the presentation, so please do have your thinking hats on and come with questions. And you are welcome to use the chat function throughout the presentation or at the end. I will be monitoring the chat and I'll make sure that your question gets answered pending time. Or you're welcome to pop your hand up or unmute yourself and simply ask a question. And if you are a tweeter, Twitter, X, I'm not quite up to date with what we're doing there yet, but we are at UCRH_NC. So without further ado, I would like to introduce our presenter today. We have Chris Williams joining us. And Chris is presenting what is the role of lifestyle in the management of chronic musculoskeletal pain. The topic, just to give you a little bit of background. So lifestyle risk factors like weight, smoking, physical inactivity, poor nutrition, sleep quality, and high alcohol intake are believed to influence the persistence of musculoskeletal conditions such as chronic back pain and osteoarthritis. This makes lifestyle risk potential treatment targets to reduce pain, disability, and improve other patient-important outcomes. However, beyond observational studies, there is little research about the role of targeting lifestyle risks in the management of chronic musculoskeletal conditions. A little bit about our presenter, Chris Williams, today. Chris is a health services associate professor. Chris is a host as a health services researcher who conducts clinical and implementation trials on treatment and preventative health solutions for musculoskeletal conditions and associated chronic disease risks. Chris previously trained and works in exercise science and physiotherapy. He completed a PhD at the George Institute for Global Health and Sydney Medical School in 2013. He is an NHMRC Investigator Fellow and has served as Program Manager in the Capacity Building Team for the Hunter New England LHD since 2016, and as Research Development Manager for the Mid-North Coast LHD. His work involves agencies such as the World Health Organization, Australian Clinical Trials Alliance, New South Wales Health, and New South Wales Regional Health Partners, NHMRC Centre for Innovation in Regional Health. So, if you will please join me in welcoming Chris, I'm going to stop my share and hand it over to you. So, welcome.
Thank you, Hayley, and thank you for the invitation to talk today. And certainly thank you to everyone for taking time out of their afternoon to listen to me talk about stuff. I hope you get something out of the discussion. I'll just try and share my screen, which I always seem to bugger up. You can see the desktop. Good. Excellent. Yeah, so thanks for the introduction. Yeah, before I begin, I'd just like to echo the acknowledgements to country and pay my respects to elders past, present, and future. From wherever you might be joining, I'm joining you from Yagle country in the Clarence Valley. And I'd especially like to acknowledge the custodianship and care of Aboriginal people from these lands for generations and generations, and extend that acknowledgement and respect to any Aboriginal colleagues joining today. And before I begin, I'd acknowledge an enormous team around this particular work. Some of the photos you can see down the bottom, you may know some of those people, but yeah, thank you to every one of those people for doing the hard work so I can turn up to these sorts of things and just talk. So today, just to give you a quick overview of what I plan to talk about, I'll talk a bit more about the background of musculoskeletal pain, and then we'll go into unpicking some of the links between lifestyle and other chronic diseases. And then I'll present some new findings about some of our work in integrating lifestyle and musculoskeletal conditions in clinical care. So is that better? Bothering people? Is that better? So just a bit of background. Musculoskeletal conditions are a bit of a problem. This is a messy diagram, of course. It's from Australian Bureau of Statistics data. It's just showing or ranking chronic diseases per 1,000 population. So this is data for disability adjusted life years. As you can see here on the right-hand side, these are the newest data. Back problems or back pain and related problems rank 3rd out of all chronic diseases. Osteoarthritis 11. The thing to note here is the increase in the burden of some of these conditions. So long story short, we're not doing a very good job of helping people who are suffering from these. And that's a similar picture across the world. So low back pain is considered the leading cause of disability across the world. These are data for years lived with disability. So musculoskeletal conditions rank 1st, and low back pain out of those conditions also ranks 1st. So these are level 4 data, and the image on the left are level 3 data from the Global Burden of Disease study. When we talk about musculoskeletal conditions, there's a few that sort of go into the pot. Back pain's one, neck pain or cervical pain. Osteoarthritis is a joint condition. And then there's a few others that get thrown in there, other joint conditions or joint pain and falls or osteoporosis sometimes gets folded into the mix. I'll be talking almost exclusively about back pain with a little bit of osteoarthritis thrown into that. So this is what you typically hear about when you think of musculoskeletal conditions or back pain, joint pain, that their pathology is related to the joints and muscles. But there's a real move away from considering musculoskeletal conditions as uniformly pathological problems related to pain or the result of an injury. And that's largely because there's a lot of evidence now showing that the pathology that we sometimes think about for back pain, osteoarthritis, is actually not correlated with the pain itself. So there are people walking around on the street who have these sorts of disc bulges and spinal pathologies that have absolutely no pain at all. The other bit of emerging evidence is that there's increasing recognition of links between broader health factors and pain. So other determinants that are likely to cause pain, and we call this a biopsychosocial model. It's common in many chronic disease models, but basically it outlines that there's biological factors, psychological factors, and social factors which may contribute to the development and or persistence of painful conditions. our group has been interested in a little bit of an extension of this model, in that we're trying to connect the dots and understand the impact of interactions between musculoskeletal conditions and other chronic diseases, and certainly behavioral factors, or so-called lifestyle factors, such as gaining weight, smoking, inactivity, poor nutrition, alcohol, and sleep to a lesser extent. So the reason these ideas have emerged are really concerned with two bits of evidence, or two areas of evidence, sorry. And that's the first is that musculoskeletal conditions and chronic diseases are often occurring together. So someone who comes in to see a GP or a physiotherapist will often, for back pain or osteoarthritis, will often have another chronic condition that they present with. For example, there's again data from the it's a national health survey from the Australian Bureau of Statistics, more or less showing that those with cardiovascular disease, about half of the people with cardiovascular disease also have arthritis, and a fraction of people with cardiovascular disease also have low back pain. We've also collected some other data locally when I was still around Newcastle. So this is the Hunter New England Better Health Study. These are community health presentations, just under sort of 12,000 people. And the top row here shows people with musculoskeletal conditions and the chronic diseases that they present to care with, and the bottom row, people without musculoskeletal conditions and the chronic diseases that they present with. Don't read too much into the odds ratio, basically suggesting that people with musculoskeletal conditions have about double and a little bit more the prevalence of other chronic diseases. The other bit of evidence is again, observational evidence. So these are systematic reviews and meta-analysis of observational studies or cohort studies, showing that people who have particular lifestyle conditions like obesity or poor lifestyle behaviors such as smoking have increased incidence of low back pain and increased risk of that low back pain developing into a chronic condition. The problem with all of this, however, is we don't know how these things are interacting. So we don't really know if, for example, smoking is causing low back pain, or if low back pain through compensatory behaviors or other mechanisms is causing people to smoke more or take up things like alcohol, be less active, for example, or there's an emerging concept around eating for analgesia, which may lead to the consumption of more fatty foods and sugary foods, leading to weight gain. So we really know little about these interactions and what's causing what. And the reality is, when we sat down to sort of try and unpick this, is that we came to the understanding that it's probably a lot more complex than single interactions. So I'm not going to explain this diagram too much, other than to say that some of the reasons that we might have observed these interactions through observational data are through confounding effect modification. So, for example, nutrition affecting obesity, which could affect chronic pain and/or chronic diseases. And I guess the striking thing that we realized is that, or the likely scenario is that these factors are likely to be bouncing off each other. So similar to the situation I described before, where someone in pain may be eating for analgesia, which leads to weight gain, which then leads to chronic inflammation and higher pain. The other bit of, or the other interesting finding when we started to scope out this, is that this is not just happening in adults. So increasingly discovering that there's an interaction between lifestyle chronic diseases and chronic pain in adolescents and children. I won't talk about that area of work today. That's largely being led by Steve Camper at an event in Blue Mountains. So research questions into the nitty-gritty of this. We decided to tackle 3 main questions initially. So the first being, does having a musculoskeletal condition lead to a higher risk of chronic diseases? Secondarily, do lifestyle factors cause musculoskeletal conditions? And a subset of that question is, does reducing lifestyle factors improve the outcome of a musculoskeletal condition? So we decided that the second question, so based on some consumer input into this research agenda, we decided that the second question was not of the highest importance and actually a little difficult to tackle. So that moved down the order of priority. And what I'm going to present today from here is 3 studies that we conducted trying to unpick these problems. So the first study, this was a systematic review. So just going back to the concept here, we've basically thrown everything into a bucket previously, and what we're aiming to do here is unpick a very particular part of that puzzle. So does musculoskeletal conditions contribute to the development of chronic diseases? This is actually published in BMC Medicine. What we did was conduct a systematic review and meta-analysis, where we looked at cohort studies investigating the longer-term development of chronic diseases in patients with or without musculoskeletal conditions. But the starting point here was really to think about, well, is there a plausible connection here? Because musculoskeletal conditions are unlikely to directly cause something like diabetes. But there's possible mechanisms by which that might occur. For example, some treatments that people with musculoskeletal conditions or chronic pain often are provided may lead to chronic disease. So non-steroidal anti-inflammatory medications are one where there's noted evidence around the increased risk of cardiovascular events, for example. And then the other plausible mechanism will be through lifestyle changes. So someone with pain and disability may engage less in physical activity. Again, going back to the eating for analgesia, increased substance use, etc. So we decided, yes, there's a possible link here, but the starting point is to actually assess if those with musculoskeletal conditions have an increased risk of chronic diseases compared to those without musculoskeletal conditions. So these are all, we included only cohort studies. Patients had to, so they could have a musculoskeletal condition or not, but no patient person in the cohort study could have a chronic disease at baseline, and they needed to follow those patients over a period of time. So this involved meta-analysis of hazard ratios of the association between musculoskeletal conditions or not and a chronic disease. And we only included adjusted estimates here. So we're really talking about causal connections, but admittedly, we didn't do a very good job of mapping out the things like confounding or the likelihood of these estimates being attributed to causal connections. So a surrogate of that was to only include the most adjusted estimates in these studies. And we did some subgroup analysis by musculoskeletal condition and chronic diseases. So we included 13 studies, longitudinal studies, just over 3 million people. There was a range of conditions or exposures and outcomes. The meta-analysis included just over 2 million people. And these were of studies that, as I said, provided adjusted estimates. That's just to say we excluded studies that included people that had a chronic disease at baseline, which I covered before. So this is the forest plot. Don't take too much notice of it. The overall estimate here is suggesting that yes, there is an increase, but only small increase in the risk of someone with a musculoskeletal condition developing a chronic disease in the future compared to someone without. So that's a really blunt departure point from that area of work. It's an ongoing area of investigation for us, but I'll get to some points a little bit down the track. The majority of our work to date has been in this realm. So for study 2 and study 3, which is really about unpicking the role of targeting lifestyle in musculoskeletal in the management of musculoskeletal conditions. So really here we're asking the question, does or do these factors cause poor prognosis? And if we change them, can we improve the prognosis of chronic musculoskeletal conditions? So we were lucky enough to pick up a project grant to test a model of care, a healthy lifestyle program for chronic low back pain. So here we're targeting weight, physical activity, poor diet, and smoking for people with chronic low back pain. And we compared that treatment to what we call usual physiotherapy care, which is actually guideline-based recommendations for physiotherapy, including education and physical activity, exercise. And we assess the outcomes of this program over 6 months. So this is the treatment program. So patients were allocated to, as I said, the healthy lifestyle model or usual physiotherapy. The healthy lifestyle model involved 5 consultations with allied health professionals, 4 with a physio, 1 with a dietitian. We also provided some health education resources and access to telephone health coaching, including the New South Wales Get Healthy service and Quitline. So the New South Wales Get Healthy service is a healthy lifestyle coaching, free healthy lifestyle coaching service involving telephone-based support over 6 months, and Quitline likewise provides telephone counselling for smoking cessation. So the consultations involved some typical staff assessment, guideline-based education and advice, but the novel part of this for physiotherapy care was the integration of lifestyle behaviour change strategies, including goal setting, graded task assignment, addressing barriers to changing lifestyle. There's some monitoring aspects to the behaviour change model, and all this was based on motivational interviewing principles and cognitive behavioural therapy. And the idea here was to create a compelling link and integration between the typical pain management approach in physiotherapy and concepts around lifestyle. So we went to extensive efforts to communicate those interactions. We developed this wheel. It's called the help wheel, which is really about giving patients or empowering patients to drive their own decisions or drive decisions about what their treatment plan looks like. So this was an interactive tool. Basically, patients could click on each of these wedges to uncover some information about how that particular wedge contributed to their back pain and their back health. And then the clinician would engage in a conversation about readiness for change and options to target some of these lifestyle risks. And so it was sort of a self-selected process for patients to define the ingredients of their lifestyle or help program. Another form of integration that we focused on was more on the functional space. So I've just talked about normative forms of integration where we've got concepts of care being integrated, different concepts of care being integrated into physiotherapy. But we also focused on this service and functional integration, which across this sort of lateral sphere, where we looked at better referral pathways, follow-up mechanisms with the telephone services, for example, better data collection and data transfer mechanisms. So sort of lowering the clunkiness, if you will, for patients to move across these systems and services, so they had a more seamless journey. So the methods, we looking for nearly 350 patients with persistent low back pain, which is pain that's of duration longer than 3 months, and they needed to have at least one healthy lifestyle risk factor, including being overweight, being inactive, having a poor diet, or currently smoking. So we finished recruitment for this study at the end of 2019. I talked about the control previously, but basically it was guideline-based physiotherapy, and the patients could have up to 3 consultations. Actually, we didn't limit this, but that's just how it turned out. The main outcomes were disability measured by the Roland-Morris Disability Score. We also looked at pain and a range of other outcomes, including the health behaviours. And the analysis that we conducted were intention to treat. We looked at a mediation analysis, which I'll go through in a minute, and we did some process analysis, a mixed method process analysis, economic evaluation, which is ongoing, and this case model, which is a complier average causal effect. So basically looks at the effect of the program in people who comply compared to those who would comply in the control group. So it in some ways upholds randomization and does a per protocol analysis. Sorry. It's just a note to say that we pre-published our protocol and also our statistical analysis approach. It's increasingly viewed as gold standard for clinical trials. There's a list of the outcomes, including the secondary outcomes, so all the health behaviours, quality of life. We looked at psychological distress and pain self-efficacy as well. And these were measured over 12 months, but the primary endpoint was 26 weeks, which corresponded with the end of treatment. A note on the analysis, so ample power, and as I said, we conducted these sensitivity analysis for the complier effects. So the characteristics of the patients, the average age of 50, slightly more female, a low unemployment rate, as typical in this population. Pain duration here was surprising, so 12 years of pain, which is a heck of a long time for someone to be struggling with these sorts of conditions. And the disability is somewhat similar to population norms. The average weight was a little bit high, but we expected that based on the targets and the inclusion criteria. So for the overall effects of the program, this is the primary outcome, disability. We saw a small and clinically So a non-clinically meaningful effect. So a 1.3 point reduction out of a 24-point scale in disability. And the case model, which is the complier effect, so that's in people who complied with the program compared to those who would have complied if offered. We've found a clinically meaningful effect. It's important to note here that this is actually compared to best practice. So this is not compared to no intervention or wildly harmful care. So we're getting a bit of a small effect. The question, of course, is whether that's worth it for the cost. And we see a similar picture with weight and quality of life. However, we found there were no changes or no differences between groups for pain intensity, nor smoking or mental health. Sorry, psychological distress. Some of the exploratory outcomes here were that we actually found a large increase in healthcare use in the intervention group, which was surprising. It's questionable as to whether that's related to the intervention or not, based on our questioning technique. So we basically captured a self-reported diary of healthcare use. We didn't use MBS or PBS information. The compliance adherence was an interesting one. So there's the mean attendance at the consultations was 3, and that was pretty similar to the usual care group. However, based on our compliance, including the referral pathways to the telephone services, there are only about 40% of patients who complied to what we would call an ideal dose of therapy. Okay, study 3. So this is a mediation study looking at the indirect effects of the previous trial. So just to explain what I mean by that is that we've tested whether the intervention, i.e. the healthy lifestyle program, leads to a certain outcome compared to the control. Here what we want to know, so we call that the total effect, sorry. Here what we want to know is whether that change in outcome was attributed to certain mediators or mechanisms. We call that the indirect effect. Sorry, the indirect effect plus the direct effect of the mediator on the outcome. So just to highlight that a little bit more, we've got a lifestyle intervention where we measured pain, disability, and quality of life over 6 months. Our targets here are actually diet, physical activity, smoking, psychological distress to a lesser extent, pain, self-efficacy, and weight. So these were the hypothesized mediators or mechanisms by which we thought the lifestyle intervention might impact pain and disability. So we went about testing that because at the moment we weren't really sure whether the change was attributed to these things or other mechanisms. So just very quickly, this is how we measured the mediators. So self-reported weight, food frequency questionnaire, self-reported physical activity, self-reported pain self-efficacy, and the Kessler-6 questionnaire for psychological distress. And we've talked about the outcomes previously. I'm only going to I'll only present the information on disability here. That's incorrect, sorry. So that's a typo. That's supposed to be pain intensity at the top, but I'm going to talk about the outcomes and the mediator models for disability at 26 weeks. So we use the causal mediation analysis here, and we're just looking at single mediators, so not a joint mediator model. And we assumed independence between these mediators, which is a bit of a punt. We also included confounders in the model. So in a randomized trial, this pathway is randomized, and so is this pathway. So we're pretty comfortable with the with any effect of confounding. However, this pathway here is not randomized, so we need to consider, are there other reasons that might explain any association we see between the mediator and the outcome? And we did some sensitivity analysis to look at residual confounding. So let's talk about. So these are the results. So this is the mediator models. So keeping in mind, these are independent analyses. I've just grouped them together for the purpose of describing the results. We found that the intervention did change diet and weight. So we've got a consistent overall effect, between the lifestyle intervention and disability. It also changed weight and diet. However, it broke down in this pathway between weight and diet and disability. So it's more or less saying that the change here was not attributed to disability. And this is for smoking and physical activity. The difference here, I guess, is just that we didn't change physical activity and we didn't change smoking with the intervention, but still the effect broke down in this path B here between the mediator and the disability. So this is suggesting that actually these targets might not be ideal targets for low back pain disability. This is a little bit of a surprise. We found that the intervention did change pain self-efficacy, and in fact, most of the total effect between the intervention and disability was explained through self-efficacy. So the overall effect, or the overall total effect was, so this explained, I think, about 80% of that total effect. I think about 0.5, so reasonably high contribution to the effect of lifestyle interventions on disability. And this is just a final note about distress. So we didn't really change distress or psychological symptoms too much, but based on the mediation model, it looks like it is actually a good target. So that's something to think about in the future. So if we could do a good job of changing distress, it may have a more profound impact on disability in these sorts of programs. Okay, pretty much done, but just to wrap up, yeah, so I guess on reflection of this body of work, it's still an emerging area. There are only 2 trials of lifestyle focused programs internationally for low back pain, and I think about 5 for osteoarthritis. The other reflection for me is there's probably little appreciation of the causal connections between these types of interventions and the outcome. And so although we found that lifestyle interventions may improve musculoskeletal conditions, they probably don't work through the targets that we think they work through. And so I guess our take on that is to routinely routinely conduct causal mediation analysis in the trials of these sorts of interventions, complex interventions, to understand whether the intended targets are changing the effect, or whether we should change the program or intervention accordingly. I'll stop talking and open it up to any questions or comments.
Thank you, Chris. That was a wonderful presentation. Let me just grab the chat up again. There was a question in the chat, very briefly, from Kerry. Is the help wheel available for us to use as a resource?
I can send you that to use if you like.
Great. Kerry noted. Kerry, if you want to share your email with me, I can pass it along to you through Chris if you like.
Yeah. I can also share the protocol, which gives a pretty thorough description of of the program.
That'll be wonderful. I think Carrie is still online with us. So yeah, Carrie, please feel free to send me your email directly in the chat. Do we have any questions from anyone? Is there anyone with their hand up?
Yes, I have a question. Yes.
Welcome, Colin. What's your question?
Okay, I'm just looking. Self-efficacy refers to an individual's belief in his or her capacity to execute behaviours necessary to produce specific performance attainments.
Yep.
I think that means that as the patient believes they can do something to change their lifestyle, they're going to get better.
Yep.
Correct. Isn't this just what's also referred to as placebo, which is presumed to be a negative thing, but I think it's a positive thing. It's just healing.
Yeah.
I believe they're going to get better, they'll get better.
Yeah, I mean, so back to the biopsychosocial model that I presented, probably didn't go into too much detail there, but yeah, these conditions are definitely influenced by psychological, social, and biological factors. And so, pain is actually it's a protection mechanism. It's a danger signal. And so if someone thinks that moving, for example, is dangerous, then it's normal for them to experience pain when they're moving. So, and I should preface that by saying I'm not suggesting people it's in their head or they're making it up unnecessarily. But so if a movement is threatening and dangerous to someone, then they will feel pain. And so if they're confident to move, for example, they're told the right things, that moving is safe and it's good for them. There can be an influence on pain without them moving. But when, certainly when they go to move, it's less dangerous, less threatening, and should not cause as much pain. That's a very simplistic view of that sort of treatment approach. But I hope the point comes. I mean, to your point about placebo, I believe it's different, slightly different. I think placebo is a methodological tool that we use to reduce bias. I don't think it's otherwise a real thing. I'd prefer to call them non-specific effects. So things we don't know about or don't measure that are actually real, causing a change in someone's health state, whether that be psychology or through biological mechanisms. Pain self-efficacy is one of those. It's sort of a big construct that involves a lot of things, but I'm not sure it's placebo. I think these are real changes, but we don't measure them or don't know how to measure the changes very well. Don't know what they are.
So like you, I view placebo as a research concept, but in a clinical situation, that thing referred to as placebo is very important. It's basically healing.
Yep. I reckon call it that then.
Okay.
Yeah. Can I actually just follow up to that question? With placebo, I think it's usually assumed that the placebo effect will dull over time, but with the pain self-efficacy, have you found much evidence for that figure decreasing over time? And what happens over time after the intervention has been implemented?
Great question. So maintained to 12 months, but don't know beyond that. Yeah, it's something that a colleague and I were sort of talking about today, actually, and especially, so going back to the first study, which was about, does musculoskeletal conditions cause changes in the risk of chronic diseases? In this particular study, we're interested in looking at the effect of changing lifestyle in a musculoskeletal model on the development or risk of chronic diseases into the future. And so, sorry, the point being, Hayley, we're likely to do a longer term follow-up of this study.
Yeah, look forward to seeing what happens longer term. We have a few more questions on the chat. A question from Ross. Thanks, Chris. Without being too cautious, what advice would you give to practitioners on the basis of this research?
In terms of lifestyle, I think I think we've demonstrated in one trial that I've already haven't filled the brief, Ross. I'm being too cautious, I think. Yeah, so in one trial, I have confidence based on the trial acknowledging my bias, that lifestyle, focusing on lifestyle is a good thing because it moves people away from this pathological biological model, which is so dominant in primary care and even physiotherapy. And you know, the evidence is really clear in my view that that's not what causes the most amount of disability for these patients. And so if focusing on lifestyle helps shift that a little bit, I've a lot of confidence to say to clinicians that you should consider having healthy conversations with patients to just to move, you know, nudge that that thinking and fear a little bit to a positive for patients. Whether they work through changing lifestyle, I'm not convinced. So, and maybe it's more appropriate then to be saying, well, yeah, focus on self-efficacy. So building confidence, capability, knowledge, and empowering patients to, yeah, to move is a good thing.
Ross just followed up. Just tell me what to do in my clinical practice. Actually, I think just like further to what you were saying, David has also asked the question, which we perhaps have kind of touched on just there, but given the lack of experimental evidence for lifestyle interventions for chronic pain, why is this the major push for chronic pain management? Is this based largely on plausibility rather than evidence?
I think you're right, plausibility, 100%. And you know, there's just so much observational evidence available about these links. And so I think it's that. It's, you know, not only does it make sense, but there is some evidence to support that logic. But I'd agree, David. I think it's probably a little bit overdone.
Thank you, David. I see a thumbs up. Do I have any other questions from anyone in the Zoom room? If you want to put your hand up or unmute yourself or jump into the chat, please do. Okay, I've got one here from Michelle Jack. Thanks, Chris. Really interesting and surprised to hear there are so few trials. From your research or knowledge of the field, can you comment further on differences in rates of musculoskeletal conditions across different chronic diseases? I'm particularly interested in type 2 diabetes.
I can, but not very well. I mean, I can comment, but not very well. So most of the evidence is, most of the cohort studies we found were looking at cardiovascular disease. I think there was only one cohort study investigating diabetes, which did find musculoskeletal conditions increase the likelihood of diabetes. Again, don't know why, and I can't give you an estimate of the size of that risk. Sorry, Michelle, but I can drag it out and send it to you if you like. But yeah, good evidence for cardiovascular disease of a small increased risk. Other chronic diseases are a little bit questionable.
Thanks, Chris.
Thank you, Chris. Do we have any other questions? I'll give everyone a moment.
I can send the slides, Paul, if you like.
Yeah, that would be great.
Oh.
We've got some Hamra. Did you just want to know, did you do imaging to confirm?
No, and I think you mean back imaging. No, we didn't.
As a cause, yes, to confirm pathology as a cause.
No, so we did exclude patients where there were clinical signs that pathology serious pathology is a cause. So things like fracture, infection, quarter-equina syndrome, and we also excluded patients who had signs of radiculopathy, so yeah, signs of nerve root impingement. Yeah, but based on the clinical presentation, but we didn't do imaging to confirm those patients were more or less excluded if there was suspected serious pathology. In terms of other things like osteoarthritis, facet joint degeneration, disc bulging, herniation, those sorts of things, we didn't confirm by imaging. And that's because the evidence suggests that those things play a minor role in chronic low back pain.
Thank you. Great. Hope that answers the question, Hamra. If there are any other questions, time to speak now. I do also have a question. I understand that this is, from what I guess I picked up from what you're saying, it's just incredibly complex when you start looking into lifestyle factors. This is an incredibly complex landscape that we're just barely scratching the surface from, and it seems like this needs to be almost mapped out. There's no simple solution. I was wondering, it's kind of a two-part question in the HELP trial. Forgive me if I missed this, but what kinds of clinicians were working in the intervention group? Were they physios that were specifically trained? Yep. And within that trial, what kinds of challenges did you face with working with like physios and training them up to kind of implement interventions like this that are maybe out of scope from traditional practice?
Yeah, so I didn't go into the details about this, but this is a co-design study with a physiotherapy department in Newcastle and others in the Hunter, New England Local Health District. So it was actually really easy to do that, Hayley, because they were part of the research team, and you know, so the grant basically provided funds for that department to lead parts of the study, and yeah, I think that came down to, you know, the research team and the clinical team forming a good relationship, good bond, and sharing the lead of the trial. Hope that answers your question.
Yeah, that's great. That sounds really wonderful. They were engaged.
Yeah, it was a really great experience.
Team.
Yeah. In terms of the challenges for the physios, though, we did do a process analysis, and the striking thing, the overwhelming thing that emerged from the qualitative interviews about delivering this sort of care was that they really wanted more support and a higher level of training for the behavioural part. So for behaviour change, and particularly around conversations about smoking. And you know, unsurprisingly, we didn't do a very good job of the smoking part of this, I think, and yeah, that's probably a good future direction for us to unpick a little bit more. There are no trials of, you know, despite the links of the observational research between smoking and back pain, there are no trials which have looked at smoking cessation for this population. Yeah, so that's probably a good area to move forward in.
I have just a couple more questions in chat, just a few more from Hamra. Would you link this to mental health issues, or were you able to find any link with mental health issues?
Yeah, the population that we sampled here didn't have a particularly high level of mental health problems or distress, or so-called distress. There's sort of snippets of that. It's an important focus. So in the mediation model, for example, we did find that second path is likely to influence disability. And that's the case for pain as well. So again, we didn't do a very good job of the mental health component to this particular study. We were more focused on those, you know, big ticket items, weight, diet, physical activity. So like my guess would be yes, that mental health plays a role. And the question though is how do we change it in this sort of setting?
Absolutely. Thank you. I have 2 more questions for you. I'm going to ask the second one first, just because it probably relates back to what we were talking about. With the HELP trial and the training for physios, ultimately, do you think this type of training for physios should be included during university? I'll back that
Yeah,
up.
I think so. Irrespective of the effect of this way of treating on pain disability, it's probably going to be a good thing for the prevention of chronic disease. And so if we accept for a second that this population, people with back pain in particular, osteoarthritis, have a higher risk of other chronic diseases, and we think through these lifestyle targets, then if we're integrating this sort of care in lots of different treatment or care exposures, then I think it's likely to be a good thing for patients. That being said, I haven't thought about the risks of doing that either. And to answer your point exactly, answer your question exactly, I think physiotherapists are would be a good setting and profession to help move this along a bit, i.e. integration of preventive care elements into clinical practice.
Yeah, thank you. And just before we finish, because I know we've got 1 minute to 5, wondering if your research has looked into patients with spina bifida, and if so, the outcome.
But we haven't, sorry. I'd be pretending if I even attempt to answer that question.
No worries.
Sorry about that.
No, that's so good. Any last final thoughts or questions from the room? For the moment. Okay.
Oh.
Would you follow up?
Happy to take any questions, and if that's what that means, my email is c.williams@sydney.edu.au.
I'll share that in the chat now.
Please reach out. Happy to chat about any of this sort of thing.
I'm just sharing it in the chat.
Okay.
And Chris, thank you so much.
Absolute pleasure. Thank you.
Yeah, it's been a pleasure to have you online. That was a really wonderful presentation and fascinating. I was rapidly typing notes, had to turn my chat off, my video off for a while. So we really appreciate you coming along and sharing that with us.
Great.
Have a wonderful afternoon, everyone. And we'll see you at the next seminar next month. Thank you all.